like to hold off on red cell transfusions until the blast count is reduced. If it is necessary, you need to give one red cell unit at a time, very slowly, with hydration. But you don't want to hydrate too much. It's like dancing on the head of a pin, because you don't want to make the pulmonary symptoms worse if they're showing symptoms of leukostasis. According to the special issue which just came out, definitive treatment of hyperleukocytosis is induction chemotherapy with aggressive supportive care. Chemotherapy agents are cytarabine plus daunorubicin or idarubicin, or anthracycline and mitoxantrone. These are some of the cocktails that they give. Tumor lysis prophylaxis, hydration, allopurinol. Hydroxyurea is an antimetabolite that slows or stops the growth of cancer cells, and then also they mature then as well. With symptomatic leukostasis, you absolutely need to have rapid cytoreduction, and that's the area where the leukocytophoresis seems to play a role. Asymptomatic hyperleukocytosis, there is a 2 to 3-fold higher mortality rate in these people that present with hyperleukocytosis and AML. But the role of leukocytophoresis in that setting is still subject to debate. M3, as we talked about, should be avoided. Leukocytophoresis should be avoided. There's no evidence that it improves, and it could make things worse. And in fact, this Vadat et al. In 1994 said that it could possibly trigger catastrophic occurrences leading to early mortality. So we tend to try to discourage the use of leukocytophoresis in promyelocytic leukemia. Rationale for leukocytophoresis: rapid reduction of the leukemic cellular burden, improves tissue perfusion, and may cause reversal of pulmonary and CNS manifestations. It can reduce the white count faster than chemotherapy alone. Whether that helps or not is unclear. In patients that have been studied with cytoreduction, leukocytophoresis plus chemotherapy versus chemotherapy alone, some have reported a higher earlier death rate, but that might be patient selection, in that the ones with really high white counts underwent leukocytophoresis in addition to the chemotherapy, so you have a selection bias which may have led to a higher mortality. You may not see any benefit of leukocytophoresis if there's already end organ damage that has occurred or hemorrhage has already occurred. Multiple retrospective studies of AML with asymptomatic hyperleukocytosis are very contradictory. Some have said that it reduces the rate of death, so it's helpful. Others have said it's no impact on mortality. Some have said maybe the early rate of death is lower, but later mortality and overall survival is no different. Other studies have found no benefit of leukocytophoresis in asymptomatic hyperleukocytosis, and have expressed concern that this may delay the start of induction chemotherapy, which is still the definitive therapy. A more recent systematic review of AML with a white count of greater than 100,000 asymptomatic from the standpoint of leukostasis found that early mortality was not influenced by leukocytophoresis, but it didn't really help. So is there a role of leukocytophoresis in leukemia without leukostasis? That's a big question mark. Maybe if you have sky-high white counts, like you start getting into the close to 1 million range or something like that, we may still get a request in somebody who doesn't have leukostasis symptoms. Or if there's evidence of end organ damage from leukostasis, let's say there's evidence of renal injury or something like that, you may get a request even though the patient isn't showing other signs of leukostasis. Bottom line, once again, though, is chemotherapy should not be postponed in these patients. What about leukocytophoresis in children and adults with ALL? If the white count is less than 400,000, the clinical symptoms of leukostasis are less than 10% in ALL patients. So there's no advantage of doing leukocytophoresis in patients with ALL that have a white count below 400,000. If it's greater than 400,000, you may see pulmonary and CNS symptoms, and so patients that present, if they have evidence of leukostasis, obviously you're going to do it. But if they present with a white count greater than 400,000, there may be a development of pulmonary and CNS symptoms even if they don't present with it, and therefore prophylactic leukocytophoresis might be beneficial. So we might see, for example, a patient present with ALL isn't really having respiratory compromise or confusion or other CNS symptoms, but has a white count of 600,000, and you'll get a request for it. And we tend to do those. At least I do when called. Technical notes, as we talked about, single procedure will reduce the white count by 30 to 60%. You don't need to use sedimenting agents for AML or ALL. You might have to do priming with selected adults with severe anemia, but be careful with that. Red cells should be avoided in small children because of hyperviscosity. You should try to maintain fluid balance of plus or minus 15% with the procedure. Duration of procedures. If you have AML and leukostasis symptoms, you want to keep going until the blast count is less than 50 to 100,000 and the clinical manifestations are resolved. AML prophylaxis, so there's no symptoms of leukostasis. You want to keep going until the blast count's less than 100,000. Closely monitor patients with M4 and M5 to see if they evolve into leukostasis while you're doing the procedures or after you finish the procedures. ALL and leukostasis, blast count, you want to do it until the blast count's less than 400,000 and clinical manifestations resolved. Leukocytophoresis until you've achieved that. And in prophylaxis, if for example someone presents with ALL and a 600, 700,000 white count, a blast count, lymphoblast count, then you want to keep going until the blast count's less than 400,000. This comes from the special issue showing the various indications. You can see that for AML and ALL, there's not much randomized controlled trial data to support what we're doing. There's some controlled trial and case series and case reports that have helped us develop our recommendations. Symptomatic leukocytophoresis, so that's patients with AML or ALL with a high white count and evidence of leukostasis. It's a grade 1B recommendation, which is a strong recommendation. Category 2, if you don't have symptoms, it's a grade 2C recommendation, which is a weak recommendation with low quality evidence, and a category 3. So that's all I got. So